Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before I get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted, so we hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speakers will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all today's guest speakers. Joining us today, we have Dr. Katherine Olshan. Dr. Olshan is a pediatric gastroenterologist at Mass General for Children. She serves as an assistant physician at Mass General and as an instructor at Harvard Medical School. She specializes in the care of pediatric patients with celiac disease, as well as other gastrointestinal disorders. She is also a member of the Center for Celiac Research and Treatment at Mass General for Children and is involved as a sub-investigator in multiple clinical trials enrolling participants with celiac disease. In addition to her medical degree from the Medical College of Wisconsin, Dr. Olshan completed her residency in pediatric medicine at the University of Massachusetts Medical School, UMass Memorial Medical Center. She also completed her fellowship in pediatric gastroenterology at Mass General for Children. Joining us today, we also have Katarina Mollo. Katarina is a clinical dietitian at the Center for Celiac Research and Treatment at Mass General for Children, specializing in celiac disease. Katarina uses her education and expertise to help patients with celiac disease and other gluten-related disorders to navigate the gluten-free diet and is devoted to educational programs for increasing awareness of celiac disease and other gluten-related conditions. Katarina was diagnosed with celiac disease as a young child, so she has lived experience of navigating everyday life gluten-free. Katarina holds a Bachelor of Science in Food and Nutrition and a Master of Education in Nutrition Education from Birmingham State University. They join us today to give a talk on gluten-related disorders. So please join me in welcoming Dr. Olshan and Katarina.
Thank you so much. All right. Well, welcome to everybody again. Thank you so much for joining us today. We're very excited to be here today and talk a little bit about the myths and facts of gluten-related disorders, which is something we obviously spend a lot of time addressing in our clinic. Neither of us have any disclosures to report. And just briefly to go over the objectives of our presentation, we're first going to discuss the presentation and diagnostic criteria, primarily for the two most common gluten-related disorders. And so those are celiac disease and non-celiac gluten sensitivity. We'll then review the management of both of these conditions, as well as highlight some topics and frequently asked questions regarding these gluten-related disorders. And then finally, we'll close by discussing some of the ongoing research here at Mass General, and then opening up for your questions. So first, a little bit of background. I first want to make sure that everybody who's attending today has a good understanding of what gluten itself is. And so gluten is a protein that's found in wheat, rye, and barley, and is made up of gliadin and glutenin. The gliadin is resistant to complete digestion by humans within the gastrointestinal tract. And so what this means is that the kind of oligopeptides, the smaller pieces, enter into the small intestine where they can then interact with the cells that line that first part of the small intestine called the duodenum. And by this interaction, they can increase permeability, which means that contents that are typically in the lumen of the GI tract are able to pass into the body and then interact with the host's immune system. And so, for example, in celiac disease, which we'll talk about more on subsequent slides, this triggers an ongoing inflammatory cascade. So taking a step back, there's a large percentage of people who follow a gluten-free diet. I think it's helpful to think about there are a large portion of people who this is a medical necessity, and there's kind of three main categories for this that I'll talk about first. And so the first one is wheat allergy, which is an allergic condition that is IgE mediated. And so typically for these individuals, when they ingest wheat, they have the kind of stereotypical allergic reaction, right? So it's things like hives, you can have swelling of your lips and of your tongue, difficulty breathing, vomiting, and even anaphylaxis. The next category is celiac disease, which is a different immune mediated process in an autoimmune condition. And then the third category is gluten sensitivity, which, as we'll discuss at this time, we don't have a great understanding of the pathophysiology and which part of the immune system is being activated. So first, thinking about celiac disease, this is a lifelong autoimmune condition once it starts that occurs in individuals who have specific genes that we've identified and is caused by exposure to dietary gluten. And as I mentioned before, what happens when these individuals ingest gluten is that the breakdown products interact with their immune system and cause inflammation in the small intestine due to an inappropriate response of the immune system, primarily through T cells. Historically, celiac disease was really considered to be a pediatric only disorder because there was a very specific presentation that we recognized for this. So this typically was a young child under 5 years of age who would present with significant abdominal pain, a very distended abdomen, would have nausea, vomiting, diarrhea, and significant weight loss. Today, however, we have a better understanding of the disease process and understand that there's a wide range of both GI symptoms that individuals can present with, as well as symptoms outside of the GI tract called extraintestinal manifestations, because we recognize that it's a systemic autoimmune condition that affects the whole body. So some of those other symptoms are things like anxiety or depression. You can get joint pain. You can get specific types of rashes, can have abnormalities such as anemia, can get osteoporosis or infertility. And as part of this, we also now recognize that it can essentially present and be diagnosed at any age. So it's not just a pediatric disorder. Thinking about non-celiac gluten sensitivity, so this is a little bit different than celiac disease in that it's not an autoimmune condition. We don't understand the pathophysiology of it. But for these individuals, when they are exposed to gluten, they get a lot of the same symptoms that I just talked about for celiac disease. So these include both the intestinal symptoms such as nausea, vomiting, belly pain, diarrhea, constipation, but can also get a lot of the extraintestinal symptoms. So things like the anxiety, depression, mental fogginess when exposed to gluten. And really, as we'll talk about on subsequent slides, this is a diagnosis of exclusion. So you need to rule out the other gluten-related disorders first. And thinking about the reactions and kind of the onset of time to symptoms after exposed to gluten can be a little bit helpful in how we think about diagnosing these different disorders. So for example, as I mentioned, celiac disease is an autoimmune condition where essentially your body's immune system is attacking the normal healthy cells in your small intestine because it's been confused after being exposed to the dietary gluten. Because this is the mechanism for it, it does take a lot of time to build up the amount of inflammation and damage to see symptoms. So often onset of symptoms is more on the scale of weeks to years. This is in comparison to something like non-celiac gluten sensitivity, which tends to have a shorter response time between the exposure to gluten and when you start having the symptoms. And then finally, the IgE-mediated wheat allergy that I mentioned is a much quicker process than either of the other two. So because it's an allergic reaction, it typically occurs on the scale of minutes to a few hours. And thinking about the diagnosis of celiac disease, so when celiac disease is suspected, the initial step we typically take or will be taken in the primary care setting is to send screening blood work. We have some really great serologic tests. The primary one that we rely on is a test called the tissue transglutaminase IgA or TTG-IgA. And this is the most sensitive and specific test that we have. And when this is elevated, makes us more suspicious that the individual may have celiac disease. And this is the test we rely on for a majority of people. There is a subset of people who are IgA deficient, and essentially, this may be something that the individual didn't know before we screen for celiac disease, but they have a lower amount of that immune cell, the immunoglobulin A. And so in that case, we would use a different test that's IgG based. In North America, the standard of care after having this elevated blood test is to proceed with additional testing to confirm the diagnosis of celiac disease. And so what this is an endoscopy where we take a look with a camera and go to that first part of the small intestine called the duodenum where celiac disease is, and can take tiny samples called biopsies that get looked at under a microscope. The picture on the left here is what a normal healthy lining of the small intestine looks like. So with this, you have these teeny finger-like projections called villi that have digestive enzymes on them. They increase the surface area of the small intestine, which helps with absorption of nutrients. And in celiac disease, you get significant inflammation in this area and get shortening of these finger-like projections or even complete flattening of the mucosa there. And so based off of that, we have a grading system called the March grading system that we use to diagnose celiac disease. And it's worth noting that it's really important that the individual be consuming gluten through all stages of this process. The blood test is only sensitive and specific for individuals who have gluten in their diet. And similarly, you need to be consuming gluten at the time of the endoscopy, because otherwise you could be in a scenario where the biopsies come back as normal and very healthy looking. And you then are in the position of, do they have celiac disease that's being really well treated, or did they not have celiac disease in the first place? In thinking about non-celiac gluten sensitivity, as I mentioned before, this is a diagnosis of exclusion. So it's made after we rule out celiac disease, rule out the wheat allergy. We at this time do not have any specific blood tests or other biomarkers that we can use to diagnose this condition. And really the way we do diagnose it is by removing gluten from the individual's diet completely and looking to see that symptoms resolve. This should be for at least a week, but ideally should be longer, at least 2 to 3 weeks. And then this is just another overview of the diagnosis of the different gluten-related disorders for those of us who are more visually inclined. And as you can see, the first kind of branch point in the diagnosis is thinking more about, is this an allergy versus celiac disease or non-celiac gluten sensitivity? And a lot of that is based off of asking questions of the individual and getting a sense of the time course between gluten exposure and onset of the symptoms. And then for the wheat allergy, an allergist would perform skin prick testing as the primary diagnostic tool. Moving down the other branch on the right, for celiac disease and gluten sensitivity, it's the screening blood work as the first step. If those are positive, as I mentioned, the next step would be the endoscopy, which is the EGD with biopsies. And if that blood work is negative, then you're more suspicious for gluten sensitivity. Right, and then I'll pass it over to Katarina.
Right, thank you, Catherine. I'm just going to change my screen over. All right. Did that work? Okay, great. So thank you so much, Catherine, for that. So now I'm going to be looking at the management of these two conditions. So what is the treatment of celiac disease and non-celiac gluten sensitivity? So both require a gluten-free diet, but may have some differences. So celiac disease requires a strict gluten-free diet. So the gluten-free diet is for life. You cannot go on and off the gluten-free diet when you have celiac disease. And following a gluten-free diet involves, avoiding wheat, barley, rye, and contaminated oats. And this includes carefully reading labels of anything that you're eating and drinking. So basically anything you're ingesting. And also watching out for cross-contact with gluten. So cross-contact happens when foods intermingle, such as during food prep. So another step in the treatment is to address any kind of nutrient deficiency, as well as, growth or weight concerns. And nutrient deficiencies are, very common with celiac disease, as it, causes malabsorption. The most common deficiencies that we see are iron, B12, folate, vitamin D, and zinc. And some people also may have low bone density due to calcium and vitamin D malabsorption. So I actually always recommend my patients to take an age-appropriate multivitamin and extra vitamin D daily for long-term maintenance. So another important step is to see your GI doctor and dietitian for regular follow-ups to monitor the celiac disease. And studies have actually shown that regular follow-ups by celiac specialists increased adherence to the gluten-free diet by over 97%, compared to only 40% in those who did not have this type of follow-up with celiac specialists. So as with celiac disease, the therapy for non-celiac gluten sensitivity is to be on a gluten-free diet. However, it is not generally necessary to maintain a gluten-free diet as strictly, or it may not be lifelong as with somebody with celiac disease. So it has been demonstrated that patients with NCGS may be able to tolerate small amounts of gluten without developing symptoms. And this is very individual. So after an extended period on the gluten-free diet, patients with NCGS, they may reintroduce small amounts of gluten, and a low gluten diet may be sufficient to avoid symptoms. And how much gluten can be eaten without, symptoms must be tested on an individual basis. And the fact that it's not necessary to maintain a permanent gluten-free diet is a key difference to celiac disease, which requires a strict lifelong maintenance of the gluten-free diet. So it's also very important to see a dietitian if you have a gluten-related disorder. So dietitians specializing in gluten-related disorders play an important role in diet education and maintenance of the gluten-free diet. And they can help with things like, diet education, diet adherence, nutrition-related issues, quality of life, and psychological burden of being on a gluten-free diet, as it can affect many areas of life, and navigating school and college environments, and really any environment that involve foods. All right, so let's delve into some myths about gluten-related disorders, and there are a lot of myths surrounding them, especially celiac disease. So I'm just going to discuss some of the most common ones that we come across in clinic. So the first one, the prevalence of celiac disease is not rising. We are just more aware of it now. Well, the fact is that celiac disease, both the incidence and prevalence, are both rising in Europe and the United States. Accurate and available accessible diagnostic testing became available about around 2000, and screening of large populations have led to recognition of celiac disease. Celiac disease is very common. It does affect 1 in 100 people. And data actually suggests that over the last 50 years that the incidence and prevalence of celiac disease has been rising in line with other autoimmune conditions such as asthma, type 1 diabetes, and MS. And recent studies focus on the past 20 to 30 years find that the incidence of celiac disease has increased 4-fold in the UK, and the prevalence have increased 5-fold over a 30-year period in the US. In a study of Italian school children, it has an increased prevalence of nearly 2-fold in the past 20 years. So the incidence and prevalence of celiac disease is actually expected to continue to rise. Another common myth is that celiac disease is a childhood disease and it can be outgrown. So celiac disease can actually be developed at any age. You cannot grow out of celiac disease. It's genetic, and once that gene turns on, and it can turn on during any time during the lifespan, it can't be reversed. And many people get celiac disease as adults or seniors. And studies have shown that the median age at diagnosis to be just under the age of 50, actually. And about 19 to 34% of new celiac cases are aged 60 years and over. And this study followed 3,500 individuals over a 35-year period and found that the prevalence of celiac disease doubled every 15 years. And the study identified people who were initially negative and then developed celiac disease after age 60. So you really can develop celiac disease later in life. And this is another very common myth that gluten has become more toxic over time. So let's look at that one. And the fact is, gluten is not more toxic, and gluten in wheat has not actually changed for over a century, despite domestication and genetic modification. So protein contents of hard spring wheats vary on average over about a range of 3 to 4 percentage points from year to year. It usually falls between the 12 to 16% range, and these values have actually not changed since the late 1920s. Another thing that I hear a lot is that people think that gluten from Europe is safer and safe on a gluten-free diet. This is not true. You cannot eat gluten in Europe if you have celiac disease or NCGS. And the fact is that Europe also have very high prevalence of celiac disease. And as I said, the United States have a prevalence of 1 in 100. And in some Scandinavian countries, for instance, like Sweden, they have an incidence of 1 in 55. So it's actually more common in some areas of Europe. So this is yet another myth I hear a lot, that sourdough bread from gluten-containing grains is safe for people with celiac disease. And this is not true. So regular sourdough bread is not safe. So the bacteria in sourdough, it does have some gluten hydrolyzing activity. It does break down some of the protein. However, the gluten content of sourdough bread products does not decrease to kind of any meaningful level to be, safe for somebody with celiac disease. And for foods to actually be able to be considered gluten-free, they have to contain less than 20 parts per million of gluten, which is a very, low concentration. And regular sourdough breads, they would, be nowhere near that. So they would definitely not be safe. However, sourdough is okay if it's from gluten-free ingredients and if a gluten-free starter is used. Another myth is that people with celiac disease do not tolerate dairy. So it's true that some may not tolerate dairy, but not everyone has to avoid dairy. Some patients may be temporarily sensitive to lactose when they are newly diagnosed. And this is due to the fact that there, is injury in the small intestinal lining, which is the area that produces the lactase enzyme. And that's the enzyme that digests lactose. And if you don't have that enzyme, you will have symptoms of lactose intolerance. So for newly diagnosed patients, it may be temporary because once your intestine heals, then you may be able to produce that lactase enzyme again and tolerate dairy. And this may take up to a year on the gluten-free diet to be, so that you're fully healed and can produce that lactase enzyme again. But again, I see many patients that can tolerate lactose at diagnosis as well. So there's no need for every patient with celiac disease to go on a dairy-free or lactose-free diet. Oh, and this is a common one too, because we read a lot about the gluten-free diet in the media. We should all eat gluten-free. And you've probably also seen, gluten-free diet touted as being, very beneficial. However, research has shown that the gluten-free diet is not protective for heart health. And it also did not increase brain function and cognition. And it also did not improve exercise performance in athletes that they studied. And there are also some other significant challenges with the gluten-free diet. And that's also one of the reasons I don't want anyone on this diet. If you have celiac disease or non-celiac gluten sensitivity or wheat allergy, you have to be on the gluten-free diet. But here are some nutrition challenges. It can be, low in fiber because gluten-free foods are usually high in starches, and starches can cause constipation in patients, especially in the beginning when you first go on the gluten-free diet. It's also generally higher in fat and sugar and also high fructose corn syrup. And this is often added to increase the palatability of gluten-free products. And gluten-free products tend to also be higher in calories, even though the serving size looks smaller. Because, for instance, gluten-free bread products, they tend to be more compact, so it just looks like a smaller serving. But sometimes those small slices of bread they have twice the amount of calories as a regular slice of bread. People on a gluten-free diets are also exposed to higher levels of arsenic, and this is due to the fact that many gluten-free products are rice-based. And the gluten-free diet is often low in certain vitamins and minerals, such as B vitamins, iron, calcium, magnesium, and zinc. And finally, gluten-free products are rarely fortified or enriched like some of their gluten-containing counterparts. So what can you do to make the gluten-free diet healthier if you do have a gluten-related condition? So I do recommend people to eat a variety of foods. Eat, lots of naturally gluten-free foods, fruits, veggies, beans and seeds, lean meats and dairy, because they're rich in, iron, B vitamins, calcium, vitamin D, and fiber. And choose the more nutritious gluten-free whole grains, such as amaranth, buckwheat, quinoa, sorghum, and teff, and millet. And then drink plenty of water and other fluids throughout the day to avoid constipation. So another thing that I also recommend to people is a gluten-free Mediterranean diet, which is also very focused on whole grains, small amounts of whole grains, but lots of, fresh whole foods like fruits, veggies, beans, seeds, lean meats, and fish. All right, so what about the next myth? You can eat a bit of gluten when you have celiac disease. No, so as I said previously, you do have to eat a strict gluten-free diet when you have celiac disease. And each time, somebody with celiac disease ingests gluten, they will get inflammation and damage in their small intestine, and this will put the person at risk for nutrient deficiencies and other complications. So a lot of people ask, how much gluten, is there a threshold? So there's no official threshold for gluten consumption. However, one study determined that a daily intake of about 10 milligrams of gluten was the threshold that produced damage to the small intestine in individuals with celiac disease. So how much is 10 milligrams? So it's actually a pretty small amount. So if you would take like a piece of regular bread and cut it up into 350 pieces, one of those pieces would contain about 10 milligrams of gluten. So that's literally just, crumbs. And this can make it, hard to manage the gluten-free diet because, you do have to watch out for what I mentioned, cross contact, especially when you're cooking and things like that. So foods don't intermingle. And that kind of leads me to the next myth, because everybody's looking for something that, would help with the gluten-free diet. Next myth is there are supplements that can safely break down gluten. And I'm sure you've seen supplements, on the shelves, that can digest gluten and claim to relieve symptoms related to accidental gluten exposure. These have not been scientifically validated, and they are not safe to use for those with celiac disease. And they can actually cause a false sense of security. Because if people take these supplements, they may put themselves at higher risk for gluten exposure. So in the end, a strict gluten-free diet is the only treatment available for celiac disease at this time. Now I'm going to hand over to you, Katherine. We're going to talk more about our center and ongoing research.
Perfect, thank you. All righty. So how can you find out more about what's going on at our center? Just a little background about the Center for Celiac Research and Treatment here at Mass General. Our group is dedicated to improving quality of life for patients with celiac disease, and also has a lot of ongoing research targeting the cause of celiac disease, with the ultimate goal of finding a cure for celiac disease other than the strict lifelong gluten-free diet. In our center, we see both children and adults with celiac disease and other gluten-related disorders. You can find us on the Mass General website, or you should also feel free to email our celiac research email address at mgh.harvard.edu with any questions. We're happy to connect with people. I did want to mention one really interesting large study that we have going on called the Celiac Disease Genomic Environmental Microbiome and Metabolomics Study, or the CDGEM Study. And this study recruits infants who are less than 6 months of age who have a first-degree family member, so either a sibling or a parent who has celiac disease. And the goal of this is to learn more about the different factors that lead to the onset of celiac disease. And to do this, we're collecting lots of demographic information about when solids are introduced, what types of solids, infections, different things like that in infants and young children, and then also monitoring them periodically to see if and when they develop celiac disease. And so you can find out more about this on our website, or also email us at our CDGEM email address. We also are currently enrolling for 3 clinical trials run by different pharmaceutical companies. The trials we're currently running are all for adult patients, so greater than 18 years old. One of the studies in kind of the upper left corner is aimed at identifying new targets for treatments for celiac disease. And as part of this study, individuals with celiac disease are asked to consume daily gluten for 14 days. And we're measuring different changes in the small intestine and blood tests and stool studies. The second trial that's in the bottom left corner is evaluating a medication for celiac disease. The idea is that it would suppress the immune response that occurs for these individuals. and potentially could be a treatment for people who either don't respond to the gluten-free diet or could be used as an alternative to the gluten-free diet. And it's a medication that's been approved in other autoimmune condition, alopecia. And so for this one, it's a 21-day trial, or the intervention is 21 days where the participant, it's a double-blinded study. So they're receiving either medication or placebo, as well as undergoing a gluten challenge. And then on the right side, we have a phase 2 study that's evaluating another medication for celiac disease. That's a glutenase. So essentially, the idea is you would take it before eating gluten, and this is a drug that's looking to be validated that would break down the gluten in the stomach to small enough levels that wouldn't trigger the immune response in individuals with celiac disease. And this intervention period is 24 days with, again, is a double-blinded study where the participant receives the medication or a placebo, as well as undergoes a gluten challenge. And so if you have any questions, we are on multiple different social media platforms, and you can email us at any time. And I think we will open up for questions now, but thank you all again for joining us and for inviting us to be here.
Oh, I also wanted to add something that there's going to be a conference on October 1st in Needham. It's called Celiac Smarts, and it'll be celiac education and updates on research and also great gluten-free foods. And you can check out more information on Children's Hospital website. All right.
Thank you so much. We are now at the end of the session, so if you have any questions, feel free to enter them in the chat. We have a question regarding non-celiac gluten sensitivity. Do people with non-celiac gluten sensitivity have any problems with malabsorptions?
Typically not, just because it doesn't cause the inflammation to the small intestine. So typically the absorption is intact for those individuals.
Thank you. We have a question regarding a person with celiac disease. Do you have any recommendations around that? If one person has celiac disease within the family, if everyone should go gluten-free at home?
So what I usually recommend is that meals that you eat together, that those are gluten-free. That just makes it easier. So for instance, dinner time, and those dinner meals are pretty easy to adjust, for a gluten-free diet. But you can still have gluten-containing items in the household. Just keep things separated, and use things like separate jars for jelly and peanut butter, because those tend to get a lot, when you double dip, you spread it on bread and you get a lot of transference of crumbs in those. Those I recommend having separate ones for the one with celiac disease, and also having a separate toaster. But I don't recommend everybody going gluten-free, because there are some drawbacks with the gluten-free diet. The other issue that I didn't mention is that it's also very expensive, like gluten-free products are very expensive. But for instance, dinner meals that I do recommend, like shared meals eating together, to be gluten-free. But it's also okay. Let's say you go into prep something that has gluten in it at the same time as you're prepping gluten-free. Make sure you make the gluten-free food first and then do the gluten-containing item, because it just prevents, risk of cross-contact.
Thank you. And we have a similar question along that. For cleaning of pots and pans, other shared items, is cleaning them with soap and water just enough, or do you need separate dedicated items, cooking items for that?
So it should be fine. Like pots and pans and kitchen equipment should be fine. Just cleaning with soap and water. They actually did a study on this, and it's enough to remove the gluten. Just wash with soap and water like you would your regular dishes, or putting it through the dishwasher. It's also okay to put mixed stuff in the dishwasher, things that have gluten on it and things that don't have gluten on it together in the dishwasher is fine too. Just that you don't see anything visible on, the items. And obviously, don't use things interchangeably. Like, let's say you have gluten-free pasta and you have regular pasta. Do not use the same scooper, to scoop regular pasta and then put that scooper in the gluten-free pasta, because that will cause contamination. So things has to be washed in between. But there's really no need to have set dedicated items. I mean, some things I do recommend, I said the toaster, for instance, because you can't really clean out a toaster. If there's a drop-in toaster, a toaster oven is okay to share because you can put down foil. And then some other items that may be tricky to clean, like colander, for instance, for draining pasta. Some people like to have a separate one, but again, optional. Cutting boards, because some people don't really clean their cutting boards well, they just kind of brush them off, and that's not okay when you have celiac disease. Like, you really have to clean it in between. So some people like to have a separate cutting board. But pots and pans should be fine, as long as they're cleaned really well. I know, like, some in between items are the cast iron pans, because you're really not supposed to clean them and scrub them hard with soap and water. So that would be the only case that you could have one dedicated for that, just because I know those pans don't do well with constant scrubbing and soap.
Thank you. Do you have any explanation to as why you may think celiac disease is increasing? Do pesticides play a role?
I don't think we really know what the environmental factor. We believe there may be like an environmental factor at play. So we know for celiac disease to occur, you have to have three things, right? You have to have the genetic predisposition, you have to eat gluten, and then there's a third player that we don't really know. And it could be something environmental. What's your take on that, Katherine?
Yeah, no, absolutely. And I think there's a lot of interesting research going on around that to try and determine that. One of the kind of hot topics right now is the microbiome and what role that could play in the shift from not having celiac disease to having celiac disease. A lot of the studies that had been done previously trying to get a sense of the prevalence of celiac disease weren't prospective studies. So, like, we can compare people who have celiac disease to people who don't have celiac disease and see if there are any differences. But we aren't able then to say, are the differences because they have celiac disease, or is it the cause of why they have celiac disease? So that's why a lot of the studies like CDGEM are trying to discover what things actually trigger and what are the differences that occur like immediately prior to the onset of celiac disease. So things like pesticides potentially may factor into that. Other things are like breastfeeding versus formula feeding for children, or a more westernized processed diet versus the Mediterranean diet, and different things like that.
Yeah.
Thank you. If an individual has been diagnosed with celiac disease, is there a reason, like, should their family get tested as well?
So we generally recommend, yes, that first degree family members get screened with that tissue transglutaminase IgA test after a family member has been diagnosed. And at least in pediatrics, we still then will also check every 2 to 3 years typically, just because of the impact that undiagnosed celiac disease can have on growth. But your thoughts, Katherine, too?
Thank you. There's a question regarding ppms. If I'm reading this question correctly, there is the 20 ppm that's the codex definition, but some conclusion about needing to reduce this limit, for instance, 10 ppm. What are your thoughts on that?
I mean, I think research really supports a 20 ppm. That would be a safe concentration. The other thing is to know that this is a concentration, not an amount. So if you have something at 20 parts per million, so if you cut it up into like a million pieces, 20 parts in that food would be, that would be at 20 parts per million. So it's been determined if you eat a regular diet at 20 parts per million, that you wouldn't really go over that 10 milligram threshold like I talked about. That was the threshold. Then there are, I think there's also some confusion because, so the FDA, both the Codex is 20 parts per million cutoff, right? And also FDA uses 20 parts as well. However, there are also certifying bodies, which are in private organizations that certify foods like the manufacturers can use. And they frequently have different levels, different thresholds. They often use 10 parts per million. But I'm not sure. I think just 20 parts per million is a very tiny amount. So if you are consuming kind of a normal amounts of foods, I mean, if you have, for instance, if you would have to eat like 17 slices of gluten-free bread to get to that 10 milligram cutoff, if the gluten-free slice was at 20 parts per million. So I would say 20 parts is still a pretty safe level. But as I said, some of the other certifying bodies, they keep theirs at like 10 parts per million. But I'm not sure if this is something that they're gonna reduce it to, or I don't see probably a point of doing that at this stage.
Thank you. A question on celiac disease. What percentage of people with celiac disease on a strict gluten-free diet do not respond to the diet? For instance, intestine does not recover.
Right. So there's non-responsive celiac disease, and that's estimated to be 7 to 30%. And non-responsive celiac disease is if somebody doesn't improve within the first year. But we find that most of the time it's because of, inadvertent gluten exposure. So once you address that, by seeing a dietitian, most of those can be resolved. But there are, others that will continue having problems. There could be other issues as well that you would explore, other related conditions as well. What are your thoughts, Katherine?
Yeah, no, absolutely. And I think part of what's tricky sometimes to get an answer to the percentage question is there probably is a subset of people who their symptoms get better, but we don't necessarily know that the inflammation in their intestines have gotten better, because the blood tests, for example, are really great at diagnosing celiac disease, but become much less sensitive and specific once someone is on a gluten-free diet. And studies have shown the level doesn't correlate to the level of inflammation that is still there. And so there have been some more recent studies, and it is a kind of ongoing research topic in terms of should we be routinely rescoping individuals who have celiac disease, even if they're asymptomatic, just to confirm that there has been complete healing of the intestines as we would expect.
Thank you. The next question regarding a gluten-free diet, and why is a gluten-free diet not protective of heart health? What is it about gluten that's protective, or what are people missing when they follow a strict gluten-free diet?
Right. So that was some of the things I talked about in the presentation. So it tends to be kind of gluten. If you follow a kind of a standard gluten-free diet, it tends to be very high in, saturated fats and high fructose corn syrup, high in sugar, high in starches, low in fiber. So all of those things are not good for heart health. And also deficient in some nutrients as well, like the B vitamins, magnesium, calcium. So, that would be the main kind of contributor to not being a heart healthy, and not saying that gluten is healthy for the heart either, but being on a gluten containing diet, you would get, more fiber. and it would be not as high in starches and sugars and things like that.
Thank you. I have a question regarding food labeling. Can you tell us a little bit about FDA gluten-free labeling regulations, and do they apply to advertisements where they claim to be gluten-free?
So it does apply to any like packaged foods. So FDA, so for something to be able to be labeled gluten-free, it has to contain less than 20 parts per million of gluten, so that, and cannot contain any gluten-containing grains, right? If it does contain a gluten-containing grain, like wheat starch, for instance, it has to have a statement that it's been processed to contain less than 20 parts per million. So not anyone can just slap a gluten-free label on a product. They do have to follow something called the gluten-free labeling rule. I hope that answered the question.
Yes. So does that mean it doesn't apply to restaurant menus?
No. So the thing is with restaurant menus, the statement gluten-free, so it's kind of like protected FDA term, right? So something that's gluten-free has to contain less than 20 parts per million. Like, again, I said that applies to packaged foods, but FDA encourages restaurants to not use the term gluten-free unless they know the food is less than 20 parts per million. That's why you often see on restaurant menus that they use other terms like gluten sensitive or something like that. They don't use the term gluten-free because they're worried about them not following the FDA. So often I have patients that get worried when they see those terms, but it would be impossible, right, for a restaurant to know if something is gluten-free unless they're testing. So, and therefore, in general, so again, it's not illegal for a restaurant to say gluten-free, but it's encouraged by FDA that restaurants follow the gluten-free labeling rule of only applying that to something that's less than 20 parts per million.
Thank you, that's helpful. So while we see if there are any additional questions in the chat, are there any final thoughts you'd like to share with the audience?
Just to check out, our website and our social media for more information. We regularly post updates and educational materials on there. Also, we do webinars throughout the year with Harvard Medical School and National Celiac Association. And you can go to the National Celiac Association website, nationalceliac.org, to check out the Harvard Medical School webinars on celiac disease.
Wonderful. Thank you so much for spending the hour with us. It was very helpful.
Thank you for having us.
And for everyone who joined us today, thank you so much for joining us. As I had mentioned, today's session is being recorded. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.